In this video we will be going through the basics of population health and the concept of value-based care. Subsequent slides will include a brief explanation on the payment models. Value-based care is a form of reimbursement that ties payments for care delivery to the quality of care provided. It is an alternative and potential replacement for fee-for-service reimbursement. Value-based care models center on patient outcomes and how well healthcare providers can improve quality of care based on specific measures, such as reducing hospital readmissions, using certified health IT, and improving preventative care. The concept of population health emphasizes on the health outcomes of a defined group of individuals. While value-based care incentivizes healthcare providers to focus on effective care coordination, preventive measures, and evidence-based practices to improve patient experiences and health outcomes, population health takes a broader perspective by focusing on the health outcomes and well-being of specific groups, such as communities or defined populations. The federal government designed value-based care programs to drive down healthcare costs and improve patient outcomes and introduced an array of value-based care models. These reimbursement and care models hinge on advancing quality of care while increasing patient access and accounting for price at the point of care. Next, we will be looking into few of the concepts within the broad domain of population health that includes accountable care organizations or ACOs, patient attribution, and the various payment models. Accountable care is a healthcare approach in which improved health outcomes and reduced costs drive healthcare delivery and payment. Affordable Care Act or ACA officially introduced ACOs to support population health's triple aim goal. Accountable care organizations or ACOs are networks of hospitals, physicians, specialists, and other combinations of providers that contract with a payer to share the medical and financial responsibility for coordinating the care of an assigned population. A key component of the ACO payment structure is financial risk. ACOs not only tie payments to quality, but also holds providers financially accountable for the care costs of their patient population. ACO financial payment system is based on two models, upside risk and downside risk. In upside risk, ACOs are not responsible to pay back any financial losses if they exceed the agreed upon spending rates. ACOs participating in a downside risk arrangement will be asked to pay back part of the excess spending they incur. Patient attribution refers to the process of assigning responsibility or accountability for the healthcare outcomes and costs associated with a specific patient to a particular healthcare provider or entity. It involves identifying which provider or providers are responsible for coordinating and managing a patient's overall care and assessing their performance in terms of quality, cost, and outcomes. Patient attribution is often used in value-based care models, such as accountable care organizations or ACOs, where providers are held accountable for the health outcomes and costs of a defined population of patients. The goal of patient attribution is to promote coordinated, efficient, and patient-centered care by aligning accountability and incentives among healthcare providers. Types of patient attribution includes prospective attribution, which uses a look back at historical claims to identify patients' use of services and then prospectively attributes the patient to a provider group or delivery system. List of attributed patients remains fixed throughout the measurement period. Concurrent attribution, although uses historical claims data to attribute patient to a provider, but the patient attribution list is not final or fixed, and patients may be added and subtracted from the attributed list based on care patterns observed throughout the measurement period. Pay for performance or P4P models use financial incentives and penalties to encourage hospitals, physicians to meet pre-specified performance targets. Providers are eligible to receive bonuses if their performance meets predetermined measures. P4P can be either reward-based or penalty-based. Reward-based incentives would guarantee bonus payments for clinicians meeting specific performance goals, and a penalty-based system would involve withholding reimbursement if specific goals are not met. In P4P model, performance would be measured either as absolute performance, in which incentives are provided when performance exceeds a set threshold, and relative performance, in which incentives are provided if performance exceeds that of others or if there is relative improvement compared to one's past performance. Bundled payment programs generally provide a single, comprehensive payment that covers all the services involved in a patient's episode of care. Examples of episodes of care for which a single, bundled payment can be made include all physician, inpatient and outpatient care for a knee or hip replacement. In a bundled payment, the provider assumes some financial risk for the episode costs that exceed the fixed price. Bundled payment model rewards providers that deliver better healthcare outcomes at lower costs. It provides incentives to prevent duplicated tests, complications, and readmissions. Shared savings is a payment strategy that offers incentives for providers to reduce healthcare spending for a defined patient population by offering them a percentage of net savings. To participate, providers must be part of an ACO. Shared saving program consists of two approaches: one-sided or upside risk model and two-sided or downside risk model. In upside risk model, providers are eligible to earn all or a percentage of any healthcare savings their care incurs. If providers perform services at costs below the financial benchmark set, they get a share in the savings. If costs exceeds the benchmark, providers do not qualify for the savings payment and are not financially penalized. Under downside risk models, providers must refund a payer if the actual care costs exceed financial and clinical benchmarks. However, greater financial rewards are available to providers who perform well. The capitation payment model is a prospective system of payment where the payment amount is determined before providing any service. Capitation is a fixed amount of money paid per patient per month, per quarter, or per year. The actual amount of money paid is determined by the ranges of services that are provided, the number of patients involved, and the period of time during which the services are provided. If the provider produces healthcare savings, then he retains all of the payment. But if he cannot reduce costs below the payment amount, then he is fully responsible for the loss in revenue. In partial capitation, providers are paid a single monthly fee that covers a set of services furnished to a patient, such as laboratory services or primary care. All other care gets reimbursed using a fee-for-service model. In global capitation, providers are reimbursed with a single, fixed payment for all the healthcare services given to a patient, including primary care, hospitalizations, and specialist care. Next video will include the important healthcare reforms in the United States healthcare landscape.